Hi, and thank you for joining us. This is our Train the Trainer event series for Oncology Class number 2. My name is Erica Lochnan. I am the MedSurg Oncology educator for Clovis, and with me is my friend.
I am Saabia Mayu. I am the clinical educator for CPCU.
Awesome. Today we're just going to go through our presentations. We're going to take about 20 to 25 minutes per each category, just a high-level overview of what the discussion looks like and what the topic is going to cover. We will be emailing all of these presentations out to our Train the Trainer group, so that way you have access to these presentations. The purpose of this is to help give you an overview of what we're going to be looking at. We also want you, as the person who's going to help us do this class, to print out your presentation in the presenter form with presenter notes so that you can see all the notes for the presentation and you can come prepared for the teaching session. Each teaching session in real life will be 1 hour long. So if you need to practice kind of like your pacing or what that looks like, we encourage you to kind of read through this a few times and get used to the material and familiarize yourself so that we can kind of gauge our timing appropriately in the class. Now, we are going to be teaching with you, so don't worry. We're not going to be like, peace out, bye. But we want to make sure that we know we're trying to be cognizant of our time, because sometimes we can talk too long. I'm really good at that. Or sometimes we don't talk enough and then we're really short. So we want to make sure that we're allowing the appropriate amount of time for learning. Okay, so as we are going through these topics, we're just going to do a good high-level overview. And then if you have any additional questions, feel free to reach out to Sayabia and myself. All right, so without further ado, the first topic that we are going to be covering is tumor lysis syndrome. So tumor lysis syndrome is an oncology emergency. We know this. We talk about the overview and the time frame, what it actually is and what can cause it, and then how fast the onset can happen. So that's what these slides are about. This is about the pathophysiology, about why the cells are breaking apart, what that does, and how that releases the components of the cell into the bloodstream. So these are very similar slides. They're just overview, different kind of views of the same thing. We're going to have hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. So you can see all that is happening on these basic pathophysiology slides. Then we're going to move into our risk factors. We broke up our risk factors into 3 different sections. One is about diseases. So if the risk factors for these diseases is listed on the screen, they have a really high risk to develop tumor lysis syndrome. Now, dependent on the treatment and the comorbidities, that increases their risk, but generally these are the risk factors associated the most by disease and tumor lysis syndrome. These are the risk factors for comorbidities. So we want to make sure that we are addressing the comorbidities of the patient, because if they have additional risk factors for comorbidities, this patient may also be high risk for developing tumor lysis. These are some of the key treatments for the tumor lysis treatment. So for those of you just joining us on Zoom land, we're going to do a 30-minute overview. I am recording this so we can send it back out to you in the presentation slide deck. We're just doing a quick 30-minute, kind of 25, 30-minute review of each topic. And then at the end of the topic, we can do a brief question answer session so we can get those questions answered in real time. And then we'll continue on to the next topic. So hang tight with us. We're just going to review it. Save your questions for the end if you wouldn't mind, or you can add them into the chat box as we are presenting. Labs for diagnosis and TLS. So these are specific to our tumor lysis syndrome. So as those cellular components are lysing, they're breaking apart, they're adding all of these additional electrolytes into our body and these different products. So one of our amazing CN3s, Erica Uphoff here at Clovis, came up with this way of filtering your labs. So on the right-hand side of the screen, it talks about how to actually do this. So you can go to Results Review, Select View, and Create a View, and then you can name it. So this is kind of cool. I named mine TLS Labs because I wanted it to be real specific what I was looking at. And then it asks you what labs you want to use, and then you can select the labs that are appropriate that you're wanting to see in the patient's chart. So if you select those labs and then you hit save, it'll keep it as a defaulted filter for your patients. And doesn't matter what patient you're in. If you want to see TLS labs on any patient, you just go to your lab results review, and then you select your filter that you applied, and it'll show you just those labs for that patient. So it's a really good way to filter out what you need in a bind. So I will like us to highlight that in our class so that way we can teach our people about how to do that so they can feel like they can use that tool when they get back to the floor. TLS lab findings. So these are some of the lab findings that are associated as far as the lab values go, but they have to be at a certain level before they can say, yes, that this is TLS and as part of their diagnosis. Now, I do have to say I'd met with Mohammed and Peter this morning, and they did give me a few adjustments to these slides. So I'm going to be doing that today. When I send out the PowerPoint, it will be the most updated version. And if you have additional questions, please reach out to me. That's absolutely fine. I can help clarify any questions that come up. But it's not really as much as content-based. It's more like on the specifics of the lab. So you'll see that when we update it, okay? Signs and symptoms. So this is an emergency. The worst things that we are trying to prevent are seizures, sudden death, and renal failure. Those are the worst of the worst. We don't want those to happen to our patient. The signs and symptoms that these can start to be leading to this direction, or like, you know, kind of tilting the scale this way, are with renal, cardiac, and gastrointestinal and neuromuscular. So it kind of talks about this high level symptom overview that you might start seeing with your patient when we're getting closer and closer to the things that we want to avoid: seizures, sudden death, and renal failure. Prevention of TLS reduces the risk. So we want to make sure that we are doing everything we can to prevent TLS from happening in our high risk patients. Well, in all patients, but high risk is, you know, where we're going to focus our efforts a lot in. Reducing the risk, we can do that by monitoring their labs 3 times a day, hydration, aggressive hydration 24 hours before, making sure they have good renal perfusion before we even give them a drug that can mess up their kidneys, right? And making sure that as long as we have good perfusion, hopefully that treatment will clear quicker and they won't have the tumor lysis syndrome. Or if they do have it, they can clear it faster and we can recover quicker from it and it won't be as severe, is our hope here. Uric acid lowering agents. So a lot of times we do give allopurinol ahead of time to help with the uric acid levels. And the risperidone can be given as either prevention or as treatment. So if you have a really high risk patient, they might give a prevention dose of risperidone before they administer a treatment that they are thinking can give that patient TLS or pretty severe TLS. So we do talk about each of those further. So we mention each symptom. So hyperphosphatemia, what does that mean for your patient? What would they look like for that? And what can that cause? So it would look like nausea, vomiting, seizures, maybe lethargy. It binds to calcium. That's what phosphate loves to do. And it makes the phosphate calcium binding complexes. We see this a lot with our our renal patients where we have to give them phosphate binders. So of course, the treatment for hyperphosphatemia, as you might have guessed with that previous statement, is to treat them for like a renal patient with a phosphate binder. So we will be giving them phosphate binders to help bind to the phosphate and hopefully less to the calcium. And that way we can excrete it through our kidneys, okay? Treatment of hypercalcemia, because the calcium is going to bind with the phosphate, it's going to lower our calcium levels even further. The real treatment for this is really to give calcium gluconate, an IV version. But if you look at our intravenous medication guidelines that the pharmacy has given us, it is only to be given through a central line. It's only to be given with a cardiac box, and it's only to be given in a critical care area. So we are not a critical care area med-surg, folks. Please do not give calcium gluconate on the floor. You are required to have ACLS, and that is in an ACLS location, in a critical care location, specifically by that guideline. So please do not give calcium gluconate to recover hypocalcemia. That is an indication that the patient may need to go to higher level of care because, of course, if we have hypocalcemia, we could have deadly arrhythmias, hypotension, bronchospasms, and all the things that come with that. So we want to avoid that if possible and get this patient the treatment that they need. Hyperuricemia. This is where the uric acid crystals start to obstruct the kidneys. So we want to make sure we're decreasing the uric acid levels. We talked about management already, allopurinol in advance. Risperidone can be given as prevention and as a very immediate treatment. It works within 4 hours, which is really helpful for your patients who are, battling severe kidney disease or impairment. Allopurinol, this is like the standard dosing that you would see ahead of time and then continued on. This does have a contraindication for it, so please point out that contraindication when you are talking about that slide. Respiricase, this is the product information off the FDA website, but that is not what we're using as a pharmacy. So that has been confirmed with Peter and Mohammed. They either use the standard 3 milligram dose or the standard 6 milligram dose. They're not going to do this whole body weight conversion. So it's okay to know about this, but I'm going to be updating this slide to say either 3 milligrams or 6 milligrams based off of what the physician and the pharmacist are agreeing upon. Okay. Urine alkalization, we do not do anymore. This is an old practice. I have a big caution here for we do not give sodium bicarb for this because it does increase the calcium phosphate complexes, which increases the risk of renal failure. So we don't do this anymore. So this slide is here as a big fat, we don't do this, know about we don't do this. If your physician asks you to say, hey, can we give him sodium bicarb? You're going to be like, that's not good practice. We're just going to do lots of normal saline and we'll use our other agents to help with the urine filtering, okay, and alkalization. Hyperkalemia. So this is really severe. Obviously, this can be really bad for your patient. High potassium levels are no joke. If you have arrhythmias, ventricular tachycardia, that can lead to fibrillations, cardiac arrest, and sudden death. So we really want to highlight that this is not a good thing. This is something that requires immediate treatment. We want to make sure we're getting our patients their care that they need. So how do we treat this? So mild, you'll see is listed there. That is hydration, loop diuretics. The use of Kayexlate is contradicted because of the bowel necrosis that is now found to cause. So that may or may not be used. It's kind of used more sparingly now because we know the problems it could have. Severe, so this is going to be interesting. Your physician will need to put in the order for D50 to be running as an infusion, and then IV push insulin will be given to help pull the potassium back into the cells. So unless the patient is severely diabetic and has a problem regulating blood sugars, this should not affect the blood sugars. This is only intended to move the potassium back into the cells. Again, though, this is usually done at higher level of care. This should not be done on the med-surg floor. If you have a crisis nurse here or someone else who is also supporting you, or maybe a CPCU leadership or something like that helping you out, they may be able to help you with this process, but this is not something that we should be doing on our med-surg location. So just kind of knowing that might be another indication, high potassium levels to get your patient off the floor into another higher level of care opportunity. Hydration support, we love hydration in this patient. So we're going to give them really aggressive hydration if they're having tumor lysis syndrome, up to 6 liters a day, which is a lot of fluid. We're going to give them diuretics, obviously, because that's too much fluid for a human to hold on to. And then we're going to monitor for cardiac and fluid overload for that patient, because if their kidneys aren't able to put that out, but we're pumping all that fluid through, they could easily overload them. So we have to be very careful with this. Urine output goals are 1 liter every 6 hours. And of course, this is going to require very close monitoring of urine output and symptoms to make sure we're not overloading our patient. So that brings us to the let's transfer the patient off the floor slide. So if the patient requires higher level of care interventions, like we talked about earlier, if their kidneys are shutting down and they need organ support, they need emergent dialysis, very aggressive hydration with exact urinary output every hour, monitoring for fluid overload, all of those things, that is going to be a higher level of care than a med-surg unit with 5 patients should be giving the patients, or even an oncology unit. You should not be doing that either at your 1-to-4 ratio. Hypercalcemia requires the use of calcium gluconate, so that would require a critical care location or floors. So that would be, again, a reason to transfer the patient. And hyperkalemia, we should not be doing this on our practice. If the patient's potassium is above 6, this is a severe event, and we need to make sure that we are getting that patient to higher level of care so that they can help monitor the patient so they don't have sudden death or deadly arrhythmias that we are not treating on a med-surg unit. So we want to make sure we're advocating our patients for this section. I think I covered this in 21 minutes, which is a new record for me. So at this point, we are going to pause for some question and answer review if you guys have any question to answer on Zoom land. And then if not, we will move into our next topic. So I'll leave the floor open for questions and answers.
Good morning, Erica.
Good morning.
And whoever else is in here. Hey, I have a question. For hyperkalemia, we've been getting a lot of orders for D50 and IV push of insulin. And we've done it too many times on our floor. Doctors don't want to move the patient. They're okay, they monitor. So is there a way that we can I think we do a lot of things on our floor that supposedly, should be done on other floors, but
Mm-hmm.
then our hospitalists are not ordering patients to be transferred. So, I mean, is there a way that they would be able to know, or I mean, for our nurses to be aware that, okay, when you get these orders, I mean, is there a place where we could look that says, okay, when doctors order, or when you get these orders, have the patient transferred to a higher level of care?
Thank you for the question, Gia. I appreciate it. So the best answer I can give you is it goes off of the standards of practice grid. So the standards of practice grid is our policy that determines whether or not the patient is still appropriate for a floor. So if the patient meets monitoring requirements that are greater than what a med-surg level of care can provide, they need to be transferred. That is a patient safety answer. That is the correct answer to follow for our policies and procedures and our transfers for higher level of care. So you can use the standards of practice grid and say, we are on a med-surg level of care physician. You're requiring something that is a higher level of monitoring, which means that you need to move this patient off the floor. And this is really, like you're saying, it's a hospital's decision to move this patient off the floor to a higher level of care. Sometimes they're resistant to that because they're receiving oncology treatments and they don't want to halt or stop the oncology treatments. But with tumor lysis syndrome specifically, the way to manage that, we're going to be doing all these things, and we should be pausing that oncology treatment for further doses until this is fully resolved. So once it has resolved, we're welcoming them back with open arms into the oncology department, but they need to get stabilized first in a critical care area. They need to complete this area, this process, right, and make sure that they're back to stable before we can even give them additional oncology treatment. So my answer to that is when you get it, because this question will come up and we do things that we're not really supposed to do. And I understand that. And we're trying to get better about how we communicate that. But we definitely want to make sure we're using our policy, our standards of practice grid to enforce our documentation that we're able to do on our floor. We need to use our charge nurses and our A&Ms and our managers more. We need to bring it to their attention and not be afraid of hey, I don't want to bug them. No, there's no bugging them. We have to use our chain of command and let them know hey, this is what's happening. The other thing that I've thought about that I have not acted on yet is I like to take this back to the house supervisor group and do another guest presentation with them. I just did one where I did CRS and ICANS with them to talk about why they need higher level of care and why this is important for the patient to move up. So I would be nice to be able to talk about this with them also, bring it back and talk about tumor lysis syndrome and why we're asking for a transition to higher level of care when we see these things are happening for a patient, because they're going to help us move these patients out of the unit, and they can help support us when we're saying that this patient needs higher level of care. They can help be that bridge that we desperately need sometimes from bedside to physician to advocate for the patient. Well, we can tell them all we want, but we really need our house supervisors to help us with that too. So I think additional education to house supervisors will also be really helpful. And now that we have I've already put my foot in the door one time with them, maybe they'll let me back for another presentation, but I think that would be a good start. Does that help answer the question, Gia?
Yeah, thank you.
No problem. Beatrice, do you have any questions at this time? Okay, hearing none, we're gonna.
I do. I'm sorry.
Go ahead.
I just couldn't find the button. Hey, Savia. So this is a teach the teacher, right? So this is what you want us to go over while we are teaching the class. So
yes.
What kind of experience or what kind of how are we teaching this class as if they're brand new, or are we teaching them that they have experience, or some of this stuff is not going to sound super foreign, right?
Right. So it's going to be a mixture of audience participants in this class. So we have some new nurses, new grads who don't even have their oncology certification yet. So they're coming in with a real low level of knowledge about these situations. So I feel like the presentation does a good job breaking down the elements, but just remember that you're not going to have a lot of experienced team members who are fully versed in this topic. So you need to kind of make sure that we're slowing down to discuss those pathophysiology things. That's why I put 3 slides saying the same thing, because I really want people to be able to grasp the concept of it in the beginning. So that way, when we're talking about how to manage it and what we're going to do to either prevent it or to help the treatment of it, it makes more sense to them.
Okay, so just go off of the PowerPoint and then we should be good.
Yeah,
And then
go
just
off the
answer whatever
PowerPoint.
questions.
Yeah, and then of course pause for the questions and let them, ask questions along, encourage questions. If you're not sure people are getting it, you can rephrase something and ask it to the audience to see if they can capture it or say it back to you. It depends on your audience too. Some audiences don't want to talk at all, and some audiences don't mind sharing. So it's a good idea just to encourage them, right? And be like, hey, it helps others learn if people ask questions and get those answers, because sometimes someone's thinking the same thing but don't have the courage to really speak up about it. So
Right.
it's good to ask the questions and if you're not getting anyone asking questions, kind of fishing a little bit and rephrasing things and throwing it back out there to see if someone will bite, basically, and help you out answering that question and making sure that they establish their knowledge along the pathway.
Okay.
This is one of the only sections, guys, that I don't have an active learning piece for. We talked about doing like a wheel, like a colorful wheel where you spin it and it has a question and you get to answer the question. But I don't really have anything planned for the active learning part of this presentation. It's always nice to have some sort of active learning just to help enforce like a critical idea or a thought. We do have a case scenario in a different PowerPoint, which we'll go through. But this one, if anyone has any thoughts or ideas about an active learning thing, you don't have to tell me right now.
After the Zoom call.
It would be cool to get some additional ideas or feedback about an active learning event for this section. Okay, if we don't have anything by the time we kind of wrap this up on Monday for the class, then on Tuesday we'll just go with the spin the wheel idea. So,
are you talking about interactive, like Kahoot, stuff like that?
Yeah, like a validation of some kind, like either a Kahoot or a spin the wheel or I don't know. But the very first time I ever taught this, I did a big board that was Velcro and I had to put them all like these different areas on the symptoms versus the treatment, trying to like line up things. And we kind of fought each other. Like one did tumor lysis syndrome, one did CRS, and one did something else. And then at the middle of the table, there was like a bell and they had to ring the bell if they got it in the right order. It's just something to help validate and enforce that they know the knowledge, they can put things together, I don't know. So
I do like Kahoot. I feel like a lot of people, especially the shy ones who are too shy to answer, so they can pick what they think, but then they get the explanation of maybe why it didn't happen or why it wasn't that answer.
Yeah, I love that. That's good, positive, real-time feedback also. So we can definitely look at doing a Kahoot for this. I love Kahoot. I think that's a winner.
Me too.
So I'll put a note for this section to potentially do a Kahoot. And then I can try to get that drafted out for you guys so you can see the questions and play, or at least I can send you the PDF of the questions and the answer so you know what kind of to expect.
Yeah, that'll be fun. I like that.
All right, perfect. We're going to move on to the next topic. So I'm going to stop sharing my screen and then I'm going to let Seabia take it away for neutropenic patient.
I thought you were going to open it. Is it?
Oh, I can do it. Here, I got it. And you have the pretty one. She has a pretty presentation, guys.
But there's stuff missing on there. No picture showing.
She has a pretty one. Okay, can you guys see my screen yet?
Nope.
Not yet.
How about now?
Says there it is.
There you go.
Yay! Okay, take it away, Seabia.
All right, so I have the topic of neutropenic patients, so the neutropenic management of patients. You can go to the next slide. So on here, I went through the learning objectives, so defining what neutropenia is, describing the pathophysiology, critical labs that are associated with neutropenia, including CBC differentials, and the absolute neutrophil count, the ANC, how we calculate that ANC, differentiating between standard neutropenic precautions from transmission-based isolation precautions, and then discussing restricted medication routes and procedures that may place these neutropenic patients more at risk. And then we continue on with recognizing the neutropenic fever and oncological emergency requiring immediate escalation. We're looking at anticipating provider orders, nursing interventions, demonstrating communication escalation workflows, including SBAR, which I think is essential for especially our newer staff members to understand once they call the doctor what the doctor specifically is wanting us to get to the point with. SBAR format usually helps out with that. We want to apply evidence-based nursing interventions and integrate standardized workflows, order sets, and documentation with all of this. So this next slide that we're going to look at is what is neutropenia. So we give an insight on exactly what this patient encompasses. So neutropenia is a condition marked by abnormal low levels of neutrophils, the white blood cells that fight bacterial infections. They also come from chemotherapy, bone marrow disorders, and immunosuppressive therapy. So that's a highlight that we want to make sure we talk about. Risk and complications. So again, we are
I stop you
highlighting.
just for 1 second, Zabia?
Uh-huh.
For the what is neutropenic, can we talk about the signs at the end of your PowerPoint that are on the door?
Sorry, can you say that again?
At the end of your PowerPoint, can we talk about the signs that we hang on the door for neutropenic patients?
Yes. Uh-huh.
Okay.
So risk and complications, we're looking at patients with neutropenia have a tenfold increased risk of severe infection. So we want to highlight some of the complications, febrile, neutropenia, sepsis, delayed treatment, all of that can be really life-threatening for these patients. Laboratory monitoring for infections. So again, we're looking at CBC with differentials. We're going to monitor closely to evaluate the WBCs, their platelets, their CMP panel. Lactate level is another critical one, blood cultures, and inflammatory markers. So some of the clinical signs and symptoms here that I highlighted, again, open for more suggestions, but fever that are greater than 38 degrees Celsius, chills, sweating, sore throat, oral ulcers, cough, shortness of breath, general malaise, and fatigue. And then we're looking at the management protocols. So we want to make sure that we are emphasizing prompt assessments, looking at the blood counts, the cultures, any broad spectrum antibiotic therapies that might be ordered for this patient, supportive care, hydration, antipyretics, and considered G-CSF in high-risk patients. So we are wanting to emphasize also how to do the calculations for these neutropenic patients. So it is the ANC, which is equal to the WC plus the segmented neutrophils plus band divided by 100. So give an example right here. A WBC is 1.2, segmented is equal to 30%, and bands is equal to 10%. So we're doing our calculations that it shows. So hopefully some of the staff members have seen the calculations of this. If not, maybe we can run through more of these calculations to get them comfortable. But the key point is that we're looking at ANC less than 500 indicates severe neutropenia. We want to look at trending values of ANC, and we also want to always verify our current lab results. So patient care and monitoring. So inpatient, we want to do continuous monitoring, IV antibiotics, make sure that they are on isolation precautions. If they're outpatient, but our emphasis is more inpatient, we want to have them follow up with their oral antibiotics if it's appropriate as they're being discharged home. More patient education given to that individual to recognize early signs and symptoms of infections and other things that might put them more at risk, and possibly have them come back to the hospital sooner than later to be evaluated. So infection prevention strategies, again, key things that we talk about here at the hospital, hand hygiene, visitor restrictions. So we want to avoid exposure for these patients if they have sick family members that want to come to visit them, or our staff in general if they're not feeling well. We want to make sure that we are also emphasizing that they are wearing a face mask as they enter these rooms. Fresh flowers, standing water, all of that. We want to make sure we are keeping that room clean and clear from that. Transport precautions, making sure that the patients are masked, and then any mucosal assessment of that patient. So again, highlighting hand hygiene is the number one intervention to reduce any type of infection transmission. Lines that these patients might be exposed to are indwelling urinary catheter. So one of the big things that Eric and I spoke of is the standardized procedure for this removal of the urinary catheter. We really want to emphasize that we're looking at the risk versus benefits for these patients in specific, because we might be exposing them to an increased risk of infection with this in and out catheterization process. Pericare is huge. We want to make sure that pericare is completed, whether or not we are having our PCT delegated to do the pericare. There needs to be follow-up by the RN to make sure that pericare has been completed on the patients. Central line care, also another big indication here. We want to make sure that we are doing our central line care, and then we are pretty much setting up this patient to be clean and clear from CLABSI if possible as we do this central line care. CHG bath, another important thing, and then the IVAD bath, also very important for our patients who we are assessing their or accessing their Mediports. Neutropenic precautions that are continued here. We do our best again to isolate this patient so they have their own private room, dedicated equipment. We are looking at their diet, making sure that we are reinforcing low microbial diets. We are looking at dietary restrictions, so no raw foods, unpasteurized products, uncooked meats, and things like that. And that's another education that we need to equip these patients when they are being discharged for home. Of course, we're monitoring their oral intake, frequent oral care for these patients, and then overall environmental safety. Again, emphasizing we want to avoid fresh flowers because that's, a lot of times family wants to come through to see their loved ones, and they want to bring fresh flowers and things like that. So we need to educate the patient and family members about this. Neutropenic precautions protect immunocompromised patients. So that's the big emphasis for all of this. Contact isolation overlay, key principle. Neutropenic precautions do not replace transmission-based precautions. Although we are trying to keep this patient as free and clean of any type of infection, we want to make sure that we are confirming any suspected organism from this patient. Any contact airborne precautions are also needing to be implemented if possible. So common organisms that we might look at are C. diff, MRSA, VRE, RSV, influenza, or COVID. Neutropenic severity classification. So I'm highlighting our mild, moderate, severe, and profound. The lower the ANC and the longer duration of neutropenia, we are placing this patient at risk for severe infection. So we always want to make sure that we are monitoring our labs. So restricted medication routes and procedures. Again, I only highlighted a few here, but open to suggestions. We talked about avoiding rectal temperatures, suppositories, enemas, avoid rectal tubes, specifically ordered, use cautions with IM injections, especially if this patient has thrombocytopenia and bleeding risk. We want to minimize unnecessary invasive procedures. Again, we're looking at or speaking of the standard precaution for removal of the urinary catheter because we are utilizing that in and out catheterization process. And then we want to evaluate our central lines daily and remove when no longer indicated. So neutropenic fever, so our oncological fevers, which are emergent, we want to make sure that we are escalating this through our charges, and then expediting this patient to be taken to a higher level of care, if possible, ICU, if that is indicated, because this patient can rapidly deteriorate into septic shock, and we want to zone in on any of these early recognitions that these patients might be having to place them into the category of a neutropenic fever. Nursing assessments and priorities. So sepsis assessments, we want to make sure that we are completing that. We are doing our respiratory status, assessing lungs, respiratory efforts, any O2 requirements, line and wound inspections, any subtle signs of neutropenia for this patient or leading towards neutropenia for this patient. So chills, confusion, weakness, tachycardia. We're wanting to look at vital signs trending for these patients. And then our escalation protocol. We want to make sure that we are in real connection and conversations with the providers, with our charges for any type of escalation that may need to happen for these patients. So laboratory monitoring, again, emphasizing what is essential for these patients, CBCs with differentials, platelets, our CMP, our lactate, our blood cultures, and inflammatory markers. This is what the sepsis screening looks like. This is what we kind of played along with just to see what populates when the sepsis screening is brought on. It highlights the temperatures, the SIRS criteria, and also highlights some of the suspected sources of infection that we can populate for this patient, and then organ dysfunction, some of the labs that we will compare it to see if this patient is indeed beginning episodes of being sepsis. So emergency response, oncological emergency, we want to notify both the hospitalist and the oncologist. We want to administer broad spectrum antibiotics or antibiotics within 1 hour. Fluid resuscitation is a big thing. Hemodynamic support, so vasopressors. So more than likely, these patients will be going to a higher level of care, ICU. And then escalate any care urgently if signs of septic shock occurs. So calling that rapid response because we are looking at fevers, chills, mental changes, severe pain, discomfort, hypotension, and then transferring that patient, like I stated, to a higher level of care to initiate aggressive fluid resuscitation, vasopressors, and other things. Orders to anticipate, so we're looking at our CBCs, differentials, we're looking at blood cultures ×2, respiratory viral testing if they're symptomatic, broad spectrum antibiotics within 1 hour, like I stated, and any growth factor support, such as the filgrastim if ordered. I don't know if ID will step in to assist us with consultation, but I know Karen is huge on supporting different things, so we could probably reach out to her for any type of additional support from ID. Order set build recommendations. So we want to make sure we're looking at our fever order sets, sepsis screening, antibiotic alerts, culture workflow. Again, escalation prompts, isolation reminders. I think maybe this is where we can talk about our signage for the isolation patient for the neutropenic patients, what the requirement is as they go into the rooms to make sure they are wearing their mask, and any pharmacy guidance that we will use for these neutropenic patients. So communication workflow, we are having our conversations with the primary provider Also, I probably should have put in this in here. Oh, it's in there. Also talking with our oncology providers, any other secondary providers that are part of the team for these patients, escalation triggers, key information that we want to make sure that we are letting these providers know about. So our ANC, any cultures or vital signs that are trending, and then utilizing SBAR format for communication, and then documenting provider communications clearly in the EHR. So example of SBAR communication. So situation A, this patient is having a fever. This is the current temperature, 101.8. The background history, day 8 of their chemo regimen or post-chemo regimen, our assessment, our ANC calculation, any vitals that are essential to let the provider know. So if they're tachycardic or their blood pressure is low, we want to make sure we're stating that, in any recommendations that they will like to give us, like should we start our antibiotics for this patient? So we are wanting to request broad spectrum antibiotics, some type of sepsis evaluation, and maybe even ICU evaluation if the condition worsens for the patient. Patient and family education, again, something else that I will be open to any more recommendations, but these are the 5 that I put in here. Teach patients to monitor temperatures at home, report any fever immediately. We want to educate patient and family to seek emergency care for fevers immediately without delay. And we want to encourage avoidance of crowds, sick contacts, high-risk environments. We want to reinforce importance of medication adherence, and we want to educate on safe food handling, hand hygiene, and infection prevention at home. Evidence-based practice highlights. So antibiotic administration within that 1 hour is associated with significant improvement outcomes. Delayed treatment increases mortality and ICU admissions. Strict hand hygiene, again, is the most significant effective infection prevention strategy. We want to standardize communication and order sets to improve patient safety. Multidisciplinary collaboration, again, bringing in not just our hospitalists, but the oncology providers for communication, because it improves recognition, escalation, and patient outcomes will hopefully be positive. So key takeaways: neutropenia impairs infection defense. So even low-grade fever may be a signal of sepsis. We're looking at that ANC less than 500 is severe. Strict hand hygiene, again, we want to emphasize that. Obtain blood cultures sooner than later. SBAR communication for rapid escalation to providers and pharmacy to either get those antibiotics started, or if we are escalating that patient, to go to ICU. And then our standardized workflows and documentation to support what we are trying to do to support the quality of care for this patient. And then my summary is: early recognition and prompt treatment saves lives. The multidisciplinary approach is essential in neutropenic management. Thank you for your attention. Any questions?
Okay, so not questions, but just some things that have come up that maybe we should put on here.
Okay.
So our neutropenic signs don't have anything about wearing a mask. So like downtown, we are doing an extra sign about putting in a mask.
Yes, I remember that.
So if we can maybe put that on there, or maybe just note it so that way they know. And then we're okay about talking about experiences, right?
What's that?
It's okay to talk about experiences.
Uh-huh.
Yeah, okay. Because we had a phlebotomist say, well, it doesn't say it on there. And the patient was totally advocating for themselves.
Uh-huh.
So like to emphasize, we need to put that other one. And then to put that other sign on there.
Okay.
And then the neutropenic diet, you talked about uncooked food and all that stuff. But if there is raw fruit on the diet tray, the patient's now allowed to eat that. And that's new for like my experience. When I first started, we couldn't have any raw,
Yeah.
nothing. And now if there's fruit on their tray, they can have that. But no, not recommended for family to bring fruit from the outside.
Okay.
Okay. And then as a hospital, can we recommend apps? Because there's a lot of apps that can do the calculations if we want them to double check the ANC, or if they want them to check the there's another calculation. Like if we wanted to check the calculations for the chemos and stuff, like there's apps out there that are used to help calculate. Do we do that? Do we offer that?
I would say I don't like the idea of promoting an app unless we know it's like validated and tested and like it gives you the right information, because the idea of doing the hands-on calculation, I'm looking for her slide that talks about that. There it is. We have badge buddies here at Clovis, and I can make some more. I was actually thinking about revising those badge buddy because it has the ANC calculation on it, and it has like a BSA calculation. It has a couple different calculations on it. But I was thinking on the opposite side, because I don't have anything on the back, we could list the badge buddies with mild, moderate, severe, and what's it called? Profound neutropenia, and like the levels that would be if you did your calculation. So like, mild neutropenia is this level, like down. So I think that might be a helpful tool. What do you guys think about me redoing our badge buddies to have like that information on the back? And then it'll say like, if you're less than 1,500, which is what our policy says, to apply neutropenia precautions, apply your neutropenia precautions to your patient.
That'd be great, because we don't even have the calculation one.
Okay, I'm gonna put badge buddy rehaul overhaul.
Erica?
Yes.
Oh, sorry. Quick question. On our calculator, the tools on Epic, isn't there an ANC calculation?
I don't know.
Remember.
I don't know. I've never looked for that. If there is one, I can definitely pull it up and see. You're just saying on like your clinical calculator?
Yeah, you know how when we check our creatinine clearance, we would just put in creatinine for that patient as long as we're on that patient. And I wonder if there's an ANC. I haven't used that.
I'm gonna look.
That might be a good thing to check.
The other thing I was gonna ask was if there's any education right now that you guys are printing for your neutropenic patients and putting in the discharge instructions, like is there already an Elsevier tip sheet or page that speaks to what we need it to say? Like I'm not on the floor, so I don't know if you guys already have something that you're commonly using. Like if you know the title of that or the name of that, I'd be happy to pull that. We'd be happy to pull that in here and saying like, you're doing teaching for your patient and family. This is a good discharge instruction one to attach to the instructions so people can see it.
There might be. Do you want me to look at that to see if there's something in Elsevier? I'll look.
Yeah, we can look for that.
I was just actually gonna do that today because I was gonna print out some stuff for the nurses, so it's just easy access. And I barely, don't be mad, but I barely finally got to go to the nursing forum for that education. And so I was hoping it was going to be in there. But we also used to have neutropenic cards. Do you know if the hospital still has those? And we used to hand them to the patients.
That
I don't know if they still have those neutropenic cards.
Yeah, it would be like literally the size of the badge buddy. And we used to give them to the patient so that way they knew what a neutropenic fever was and like some of the precautions that they used to be able to follow.
That's great. I don't know.
Those cards in forever.
Yeah, I'm not sure.
Maybe I might ask Jane Seabia. Maybe I'll reach out to her and ask her maybe where we used to get those cards.
Okay.
Because it was hospital. It was a hospital that had them.
Oh yeah, try to find out first, okay, B? And then if you find us discharge instructions, can you please send it to us, like email it to us so we can attach it?
Yeah.
Okay, great, thank you.
And then Clovis has step down too, right?
We have step down, but it's not in the same like department. It's off on a different level, different floor.
Right, but when we're saying like give the higher level of care, because ICU has limited beds, we can also go step down and they can monitor. And if they get sicker, then they can go to ICU.
Absolutely. Absolutely.
Yeah. Okay.
I was thinking about infection prevention strategies. Maybe this is not the right one. There's a slide that talked about the injections, like to limit the injections for neutropenic and all that good stuff. So for the, I don't know where it is. It's somewhere down here.
So when I go to Elsevier, there is the very first section.
It says
talks about
infection management for patients in neutropenia. That one?
Maybe.
No, this one's fever from low number of white blood cells, neutropenic fevers. Do you want discharge, like discharge instructions, or
I
just
think
information?
I think it would be great B to have both. What can you give the patient in the hospital to help them learn and understand what's going on for them, and then what can we attach to their discharge instructions to reinforce the learning to make sure that they understand? Because the other thing is that's what it was. I have two more points. So one point is this slide talking about the limiting IM injections, right? We want to make sure we talk about we're not going to give this patient vaccinations.
Oh yeah.
unless cleared by a provider, and it's, obviously like a dead virus, like we're not going to do vaccinations. No vaccinations. And then the other one I was going to talk about was the use of the sub-Q injection. What's it called that you can raise your WBC count with?
Zarzio.
Uses Zarzio to help restore the ANC count back to where, or the WBC count and everything, like getting your patient back to normal. Maybe talking about like how we can recover from the neutropenia a little bit, like saying, hey, this is a common med that we see a lot that's given, and the physicians may even continue that Zarzio and until they hit a different, like maybe they want to go above 1,500, maybe they have a different like goal for the patient. So, because I know sometimes our nurses who are not chemo certified, they'll see Zarzio, they're like, well, why am I still giving this? They're 1,000 or they're 800 or whatever. Like they're not considered whatever they had, but the physicians, but the physician's like, no, I want it here, like, so there's different goals that can go along with the Zarzio. So maybe we do a section on the Zarzio, just to kind of talk about what can help bring up,
that could be part of the treatment slide, right? Where she talks about the hydration and all that stuff. And you can also put one of the treatments would be the Zarzio.
I think it was in one of the slides for growth, growth colony stimulating factor. I think you mentioned it on one of your slides.
I did, yes.
Yeah.
Okay. Can you just put a note for that one, Ziabia? I just thought of it while we were talking.
Yeah.
Okay, friends, thank you very much. And then Ziabia, what do we have in store for the the learning event or activity for this one?
TBD. I haven't thought of anything yet either. So
okay, then I want to do a math test. Can we do a math test? I really want to do a math test.
Okay.
Map or math?
Math.
MATH.
Can I add one thing real quick?
Those tests.
Go ahead. Add something.
Oh,
go for it.
Yeah, Savia. On the lactic acid on the labs, is procalcitonin, is it standard for us? Because I've seen Dr. Abdul-Haq kind of, when we have patients that are having fever, she would sometimes add that. So I don't know if that's a good thing maybe to add it to, or do you guys see that a lot? A procalcitonin. It's just something that, would increase if it's specific to diagnose bacterial infections. It usually rises fast also, and it helps them kind of decide which antibiotic to give. But I don't know if that's, something that you guys see a lot also. But I've seen Dr. Abdul-Haq would order that. I don't know if that's like a standard compared to
not oncology. I think a lot of the doctors are going toward Procal instead of just the lactic acid. It's just another indicator.
So
maybe I don't know if that's something we could add maybe on the lab, like lactate level and then
here
procalcitonin level.
Yeah, like put it / and then put the other procalcitonin level, just to say like your physician may use both, they may use one or the other or however they prefer, but this one's coming more common. That would be great.
Okay.
Yay! All right. So I'll think about the math test. I know you guys don't like math tests, but I'll think about the math test because it's good for them to to think about it. Maybe we could do like a little case scenario and then a little math test, and then we say that they're on Zarzio, and then we have some symptoms, and then we're gonna throw like a multiple choice 4 point, a little quiz, and then one of those questions is, what is their ANC? And do they need isolation?
What's the dad's name?
All right, my friend, let me go to the next one, which is going to be our blood transfusion. The blood transfusion, fair warning, it is a longer one because we have lots and lots of problems with blood transfusion. Somehow, even though we do this all the time, we're really good at this, we still have a lot of areas that keep coming back for volumes being wrong, not completed, not whatever. So I wanted to do this good blood administration review. So this is a longer slideshow, just fair warning. I'm going to try to go through it. It's pretty fast. There's not a lot on each slide, but just kind of fair warning. And then at the very, very end, the transfusion reaction slide, there's still like 2 or 3 slides I need to put in about what our policy tells us to do based off of the type of reaction that we see. So I don't have the last 3 slides finished. I will finish them today before I leave, so you can have them in the updated PowerPoint, but just so you can see it. Okay, so here we go, rocking and rolling. There's 40 slides. Hold your breath. I'm just kidding.
Oh.
So objectives, we have objectives for the class. We want them to identify different blood types and their uses, recognize their own role in blood consent processing, demonstrate how to use a blood warmer because we need to do that annually to stay confident in it. So I'm going to throw it in here. Recognize early and late signs of transfusion reactions, summarize documentation standards and volumes, and blood product completion because that is a problem that we have. Indication for blood products. I like to use the notes section a lot more with my PowerPoint. So I'm not putting a lot on the screen. I'm going to have just the main titles there. And then the little summary will be underneath it. So when you guys are teaching this class, I want you guys to be printing out this PowerPoint in advance with the notes page there, the presentator notes here, so that you can refer back to those notes to help guide you with what these little bullets mean, okay? So we'll talk about why we give whole blood, why we give RBCs, fresh frozen plasma, and platelets, and cryo. Specialized blood product types. So this is something that the physicians can order. As we know, there are different things. So there's leukocyte reduced, there's irradiated, there's HLA matched, there's washed. So it has all little definitions and why we would use those for our patients, or why those would be ordered for our patients. Then it talks about putting in the future orders. So sometimes a physician could know that the patient's going to need blood in the future, so they can put future orders in for the patient. Sometimes you see this in surgeries and stuff like that, but they technically can still use this if they want to for putting in blood for their patients that we know.
Sorry,
yes.
Excuse me. Are you able to share your slides?
You're not seeing my slides? I'm so sorry. I thought you guys were looking
I think
at
it's still stuck on the lab monitoring for infection.
It is. I thought it was going to shift, but it didn't.
Okay, can you see now?
There you go. Thank you.
Yay. Okay, sorry. So blood administration is the first page. It has my objectives, and it has the product titles, and then the descriptions in the note, what you guys are going to kind of highlight. Then this is cut out right from the ordering screen. Talks about the irradiated blood products, and it kind of gives you this nice little summary, which is kind of cool if you ever actually read that. It's actually there for you on the ordering. And then it has why we do each of the bulleted specialized kind of treatments, and then additional options for providers if they want to put blood in for the future. Consenting blood products. So remember that this is the physician who talks to the patient, gets the consent. The consent is good for the admission. It's documented in the electronic health record. They will have the paper consent still because we're still on paper consent. So that paper consent should be signed. And then consenting for blood products, the nurse's role. So we're going to make sure that the physician has talked to the patient. We're going to go in there and have that conversation oh, did the physician come in here and talk to you about this? They were yeah, everything's good. You can make sure that they've signed their consent. You're going to help sign that consent. And then we need to give education to the family and the patient. So we're going to give education to the patient. We're going to document the education of the patient and what education we're giving them. That's what this slide goes through. So it talks about, it's important to provide this education to your patient. It talks about if you need to have So we talked about consenting, and I think in the notes I mentioned, like, if you have to have an interpreter, this is what you're going to do. If you need to have, so in these little notes, it's going to have like additional information down here. Okay, so kind of review that because I'm not doing every line for you guys. I know you can read my notes later because we are getting close. We're at our 1 hour mark. So, okay. So you want to make sure that you are giving the education appropriately to your patient. You're documenting that the education was given to your patient. That is a policy standard that you gave and documented that you did that. So if we are not saying that in our notes or selecting that in our education when we give the blood, then that is something that we're going to fall out for if they ever review us for those specifics, because we are required to do that by our policy. So be careful with that. Make sure you highlight that. Ordering blood, providers really should put in their own blood orders because of all of the little things that go with that, right? So they should know exactly what they want to transfuse. If there's a specialized washing or irradiated or HLA matched or any of that, they need to be specific about that. If they're going to tell us the phone order, we need to make sure we're repeating it back to them and we are specific on what we are ordering, because we do not want to order something that is not for the best interest of our patient. So we want to encourage them to order their own blood at all possible opportunities. If they are, adamant that you put it in, just make sure you have everything that you need when you're putting that in. Equipment needed. They can also order like specialized equipment, like the blood warmer. We do that in later slides, but this talks about equipment that's needed. Potentially, they can order for that. Type in screen when they need that because it's only good for 72 hours, pre-meds if needed. And the type in screen we mentioned as well on the next slide that says you don't need a type in screen for platelets, fresh frozen plasma, or cryo, but you do need it for whole blood and RBCs. So just kind of knowing what you need it for. At Clovis, we have a weird practice where in our policy it tells us that we have to write our initials, our ID number, and the date and time we collected it. So on the pink tube, we have to write all that on there, whereas CRMC, you guys don't have to write your ID number, but for whatever reason, we can't get updated in Clovis. We've tried, that's what our policy says, and that's what we have to follow. So I was going to take a picture of a pink tube and like write on it, but I don't have a fake patient label. So I was against that idea for now, but we want to make sure that we are just kind of highlighting that. I might just still put a picture of a pink tube just for funsies, but. And then getting ready for blood, making sure the consent is present, gathering up all your supplies, getting the saline running and checking the line, checking the equipment if it's required, getting that in the room, giving pre-meds if they're ordered, educate the patient on the symptoms that they might experience with blood and what to do if they experience those symptoms, get your baseline vitals documented, do your pre-meds. If you have pre-meds ordered for blood, you have to give them, or else you're at higher risk for reactions. So making sure that you're doing your pre-meds. It tells you why the physician might order pre-meds, and it gives you the 2 most common medications that are ordered. It also tells you the physician can order it a variety of ways. If they can do it before the infusion, they can do it after the infusion. If they're giving multiple infusions, they might order medications to be administered after the first transfusion, which if you open that, it just says Lasix, but that is another option for the physicians to select for their pre-meds. And then blood warmer guidelines, we want to make sure that they understand they can use a blood warmer. They just have to have a competency for it, which is why we're going to go through it in the class a little bit. We're going to watch a video about it. We're going to do some guidelines about it, all that fun stuff. Provider orders required for a blood warmer. It looks like this. So in the bottom right corner, it talks about additional smart set orders. And then you have to say use rapid infusion / fluid warmer. The fluid warmer is the blood warmer. It used to be embedded in the actual blood orders, but they've removed it for some reason. So now it's its own standing separate order. We never use a warmer on platelets and cryo, like ever, so please don't do that. We never use it if it's going to be above 300 mLs an hour. So if you're trying to do a quick infusion, you can't use the warmer because it doesn't have the ability or the time to warm the blood correctly. And then we like to use it for like the cold, I don't know how to say that word, so I'm not going to try, but when you have cold aversion, so like our oxyplatin patients, we could be using the blood warmer to prevent vascular damage from receiving a cold product. So it talks about that all in the notes, talks about why we'd use a warmer, what it's indicated for, what the MIF says, MIFU, and then it talks about why we would be specifically using it for lymphoma patients, autoimmune disorder patients we're trying to prevent further damage to their body, and this is why we look at it. Also gives you some guidelines for the sticker, making sure it's safe and it's been maintenance and it's appropriate to use still, making sure that the rate doesn't exceed that volume or that mLs an hour, and that we're not using pressure bags. This is our little blood warmer video. So there's a QR code here because we planned on printing out these presentations as just regular 2 slides per, page for our participants. And so I figured if they're going to have a printed thing, they can't click a link, but they can probably scan a code. So I put both on there so they can scan a code later, and then we can click the link while we're in the room. And that will just walk through a very short 3-minute video about how to use a blood warmer, setting it up and like kind of what to look out for in the tubing and stuff. So that will be really a nice little break from all of us talking. And then printing the blood release form, I get asked this all the time. How do I print the blood release form, or how do I reprint the blood release form? So the top part is how to print the blood release form. The bottom part is how to reprint the blood release form in case they are looking to know how to do that. Requesting blood products. So you can do this through the pneumatic tube system, which is the PTS, or in person. It does talk about, how to do that. And there's a policy that guides you for the pneumatic tube system about how to request and stuff like that. So I listed that there. Visual inspection. So according to our policy, we're supposed to wear gloves when we take out the blood from the clear bag to inspect it for leaks, which makes sense because we're inspecting it for leaks. But I've never put that together myself as a nurse. So that will probably be a new thing that the nurses are like, oh, really? But yeah, our policy, the 11902, does talk about wearing gloves when you remove it from the bag to inspect it. And then once it's good, it meets, visual inspection, you're going to initial it, send it back, right? But yeah, apparently you were supposed to be wearing gloves for that piece of it, which it was new news to me while I was reading this. Then we talk about the dual nurse verification. So the 2 nurses, one being the transfusionist, we are going to have the consent form at the bedside so we can view it, because you're going to pull somebody in off, the unit who needs to be in there helping you quickly. So you want to have everything ready for them. We have found that in our practice, we this is their 10th blood transfusion. Of course, there's a consent, and then they actually don't go back and look for the consent. And sometimes that consent is missing, or it's incomplete. So we want to make sure that we get in the habit of actually having the consent pulled up at the time of the dual nurse verification so they can see that the consent is done, it's in the chart, it's filed, it's appropriate. So I want to make sure that we're kind of moving forward with that. When I was on the floor back a million years ago in med-surg, that was our process. We had the consent every single time we did the dual nurse verification because it's something that we should be checking. And then we talk about the safety checks at the bedside, what we're looking at. If everything's correct, this is what you do. If there's something that's a discrepancy, it tells you not to start anything, that you need to contact the blood bank and return it immediately. And then talks about scanning. So you're going to scan your patient, you're going to hit start, you're going to scan the product. It talks about how to kind of troubleshoot that. If you are using the caps lock, it doesn't do the product number right. So remembering that, I have the caps lock off. Hanging the blood, making sure that we're spiking it either on a flat surface or on a pole. So either or is a great option. But just talking about, we have to use the primed Y-site tubing. There's no requirement for a time frame that the blood has to be spiked once you receive the blood, but they want to do it within 30 minutes of your receiving of the blood because you only have 4-hour time frame to complete that blood, and we don't want the blood to get too warm to the room temperature. It can increase the rate for infection. So if you're not going to hang it by 30 minutes, they ask that you walk back the blood to the blood bank so they can recheck the temperature. If it's still good on their temperature scale, then they can refrigerate it and keep it, and then just return, send it back up to you when you need it again. Or if it's now too warm, it's outside the 10 degrees Celsius that they actually use to monitor this, then they have to discard that blood. So that's why they are like, hey, if you're not going to use it within 30 minutes, please try to walk it back before that time frame is up. Maybe you lose access or whatever, but there's different reasons why you'd have to stop. Starting the blood. Other than cryo, we want to definitely run the first 15 minutes slower. So it talks about in our policy how to do that. RBCs, granulocytes, plasma, and platelets should be running no faster than 120 miles an hour for the first 15 minutes. And then direct observation is required by our policy for the first 5 minutes. And I did double check this because in my brain it was 10 minutes, but apparently it's only 5. And then the 15-minute mark, you need to do your vital signs again, right? And then if there's no evidence of transfusion reaction, then you can grab another nurse and then change your rates to the higher volume. So, or the higher rate, excuse me. So when you're looking at the higher rates, these are suggested right out of the policy. These are the rates that you don't want to really run past if you can help it. These are the suggested rates, okay? And then a reminder again that transfusion has to be complete within the 4 hours. Vital sign review, so before administration, 15 minutes into the transfusion, every hour until the transfusion is finished, and then at the end of the transfusion, okay? Stopping the transfusion, so at the end of the transfusion when it's completed, you still want to get the rest of the blood to the patient, so you still have to unclamp the saline and run the rest of the line to the patient to clear out the line. And that's when the blood is considered stopped. So it talks about going to the flow sheet row, making sure you click on the new box, and then you'll hit stopped there. And once you hit stop there, it'll default the rate as 0, and then you're going to add the volume in. So at no point did I say volume before I hit this slide. So we want to remind them you do not touch volume until you're at this slide. And the reason why we only add it at the end is just to remind them is like, hey, you don't know if this line's going to go bad. You don't know if they're going to have a reaction. You can't document the whole amount of the blood in the beginning because you don't know what they're actually going to get. So you want to make sure that you are only documenting the volume at the end. Okay, so just another friendly reminder there. Then you'll hit accept and complete. Then it goes to the completing a transfusion. So you want to make sure you're right-clicking on there, hit complete the transfusion, and then it will save it and put it into the HID completed section. If they want to revisit that, you'll have to uncheck the HID completed section so they can see all the other completions of blood that has been completed before. And then this one will work in on the presentation view. It'll say, when do we add the volume? And it'll be a blank screen. And then you're going to wait for them to answer you. And then you can hit any other click or arrow over or whatever. And it will say only at the end of the transfusion when the blood is stopped. That's just another quick reference point that we only do it then. And the reason why is because all these come back. So these are examples of the reports that Adelia sent us, saying that the volume is either doubled because they put it in the beginning and they put it in the end. So the machine adds it together, or they don't complete it, or there's no volume, or whatever it be. So this is just kind of a nice slide to show that either you didn't stop the transfusion, it's still transfusing, or it's completed, or it's not stopped, or it is stopped, right? So you're going to see all those options on the far right for the transfusion status. And then the infusion volume is going to show you what the nurses kind of did. And this is not uncommon, unfortunately. So this is a nice area to pause and say, you know, why might you see both? Well, because maybe the nurse who started it wasn't the nurse who finished it, and the nurse who started it forgot and they put the volume at the beginning, right? So there's still conversations around that, but you guys just kind of reinforce the fact that the volume is never at the beginning, it's only at the end. So there shouldn't be this over 600, over 400 kind of volume that's flagging us, because we get emails every single day that there's like a incomplete blood or a volume that's too far or too high or too low. So we want to make sure we're hitting that. And why that's important is because unless that blood documentation is done correctly, we can't bill for that whole PRBC or that red blood cell or that cryo or that whatever it is. So we have a huge financial loss every time all of those proceed. Like I look just for the month of May and June, we have 36 already that were wrong. I counted them. It was great. So we want to make sure that, you know, that's a lot of money that we've you know, lost when we're not documenting correctly. And it's not that we can't, we just don't all the time remember, right? Or we double up the volume. So just being mindful of that, kind of explaining that. Hopefully that'll help people understand like the why behind it. This is where I started with my blood transfusion signs. So this, if you read the policy for this, there is like 16 different signs of blood transfusion. So I didn't put 16 signs on here. I put the most common ones that we see, which are fever, chills, heart rate increase or decrease, blood pressure changes, increase or decrease, hives, skin reactions, pain, distress, and then I put more signs are found on this policy, so you guys can reference that policy for directing them back for additional signs. But there were too many to put on a slide, and that is hard to read for anybody. So just kind of review the highlights of those and then direct them back to the policy. If you suspect a reaction, the main points are stop the infusion, call the provider, notify the blood bank so they can open up a ticket. And then the blood bank will open up an investigation. The physician will give the instructions for the treatment. And there is a caveat in our policy that says you must notify the blood bank of all suspected transfusion reactions. And then the part that I didn't put on here, but I'm going to share with you guys as the trainers, because you're helping me lead this class, it says with or without the provider consent or approval. So if you think there is a blood transfusion reaction, you as a nurse are responsible for, you know, doing that process, whether or not the physician is wanting you to or not, basically. So just kind of hitting that as another option here. And then we're just going to go into acute reactions versus delayed reactions. What is an immediate sign of like anaphylactic reaction, which is very acute? What is a delayed sign, which can happen days to week after transfusion reaction that you might be needing to be aware of or understand? And that's where it's going to pretty much end as far as like other than the treatment that we'll be giving for them. So the orders to expect, and then monitoring the patient. So that's what these last two slides are going to be about, is orders to expect and then just monitoring the patient. And there is a caveat in our policy, which is what the last slide is for, that we'll talk about if it's just hives, there's a different like pathway, which is kind of funny. But yeah. Do you guys have any questions about this presentation?
Nope.
Are you sure? It's getting long, huh?
That's a lot. Oh,
if you've never given blood before, you can give blood after this presentation. Oh.
Good golly. The vital signs for the blood, it's 15 minutes and then 45 minutes later, and then every hour after that, right?
It's 15 minutes and then hourly. There's no 45 anymore. I read it out of the policy.
Yeah, I knew it changed. So if I started at 11, I take my first vital signs at 11:15,
Yep.
and then 12:15 after that.
Yep. Then it's hourly until the transfusion's over. Yep. And then when the transfusion's over, you'll complete the line with the saline and clamp the blood, run the saline to clear the line, and then that's when the transfusion is completed. We do want to tell them for the volume, when we do get to the volume section, that you're using the volume on the transfusion report that is given to you, that the 2 transfusionist sign, because that volume is the actual true volume of the blood product. It does have a preservative in it. I can't remember the name of the preservative. It starts with the C. But it helps prevent it helps the storage or the shelf life of the blood, basically. And so it's also kind of like an expander. And so it can be more volume if they're trying to use the channel volume. Also, we found that we're really not good at the channel volume because we don't clear it before the blood actually gets to the patient. So we're capturing a lot of the saline ahead of time, and then we capture a lot of the saline at the end. So we need to go off of what the transfusion document for the blood that comes up says. So there will be a volume that comes up on that bag of blood that matches the transfusion form, and that's the volume that you should be entering.
And I think Adelia highlighted that. I know she did a presentation on 7 West. I think it was closer to the beginning of this year, and she highlighted that aspect also to notate what's on the paper.
Yeah. And then so you're gonna love me, B. The interactive part of this is gonna be there. I'm gonna bring a blood warmer so we can play with a blood warmer if you're not familiar with it, if you haven't done that before. But then the second piece of it is gonna be, I have a quiz that Gian knows about because we have all of our new hires do it when we first come. But I'm gonna edit it to make it a little bit bulkier, or at least with less more stuff that we're covering in the class. So this is what. No, that's pharmaceutical. This is what the quiz, can you guys see it yet? Hold on. Share, quiz, share. This is what the quiz will look like. It's like 15 questions right now, but I want to reformat it. And it's been a minute since this was made, so I'm probably going to rephrase a few of the questions just so they make a little bit more sense. But just to reinforce the knowledge that we just gave them with the presentation, we'll give them the quiz to complete, and we'll collect that with their competency so we can file it with their paperwork. So We have where do you go on the chart to find the blood request form? Where should you go? When should you request the blood from the blood bank? And by policy, it's like only when you're ready to hang it. So don't do it while you're doing all of this other stuff because you don't want it to sit for too long. The blood will get warm. What items must be confirmed at the bedside before giving the blood? What should you do immediately after receiving the blood? So I'm going to do this little paper quiz, so people have to like circle the answers, and we'll go through the answers together, give real-time feedback on why something is right or wrong. And at the end, this is a matching that I love on what are the expected volumes to what the product is. So if they don't know, they're going to learn in the little quiz. So it's going to be fun. So I'll put a slide in at the end of the presentation about the volumes and what they should expect. And then hopefully that will help them ace this part of the test. But we want to just encourage them to remember those volumes should be, around this range, and that should be matching the paper form.
No, I think this is good. I just think like the math stuff, everybody's so intimidated by the math, and it's like, the stupid thing. Everybody just like clams up.
Yeah. And I mean, I'm okay if you want to say like there are some apps on the market. This is the one that I like, that I've seen, that I've used, that I've validated is correct. I've done the hand calculation. I've done this app, and they're the same. And this is, how I can kind of reference it. If you have the ability to kind of speak to that and like this is what we're doing with it, like that's fine with me. I don't mind. I just want to make sure people know how to do the hand kind of calculation, because if they forget the name of the app or they don't know where to go, like at least I can give them a badge that has a calculation on it, and hopefully they know how to like run the numbers,
Yeah, no, I would like the hand one for sure. But
Yay.
yeah. Yay.
All right. Last one.
I'll share this one because I didn't put it in our shared folder yet.
Oh, okay. Let me stop sharing. Hold on. Stop share. Your turn. Allow.
All right. All right, can everybody see the slide? Yes?
Yes.
Yep.
Okay, perfect.
Yes.
This one is dealing with cardiac toxicity. So we are going to be highlighting exactly what an oncologic cardiac toxicity we're referencing to, and the adverse effects for these patients on the heart caused by the cancer treatments, either chemotherapy, targeted therapy, immunotherapy, or radiation. Cancer therapies that damage the myocardium, the coronary vascular pericardium, or the cardiac conduction system. And then highlighting cardiac toxicity significantly affects patient outcomes, quality of life, long-term survival. When we move into the next slide, some of the mechanisms and risk factors. We're looking at the history of pre-existing cardiac disease and then radiation exposure, along with any type of inflammatory or fibro changes for that patient, any type of myocardial injury that is associated with that patient. Then we talk more about risk factors. Certain patients and treatments and factors significantly increase the likelihood of developing oncologic cardiac toxicity. So again, talking about the dosing of the chemo treatment that they're getting, along with any type of pre-existing disease, their age and gender play a factor, whether or not they're getting radiation or some type of combined therapy. We're looking at baseline cardiac workup for treatment, so assessing their risk, any type of cardiac history, hypertension, diabetes, smoking, and then we're looking at focus exams, vital signs, symptoms review, medication reconciliation, and then the patient, we want to make sure that this patient is on cardiac monitoring, because again, if they have a pre-existing history of cardiac issues, we want to make sure that we are on top of it sooner than later. So then key tests that we want to look into for these patients for their workup is echo, ECG, or any type of biomarkers We're going to review labs, their renal functions, electrolytes, and then we want to control risk factors that are associated with their treatment. So then I wanted to emphasize some of the therapies for that are associated with the cardiac toxicity. So I struggle with this word, anthracyclines and HR2 therapies. So they are known to emphasize LV dysfunction, heart failure, and then some of these anthracyclines, doxorubicin, and the HR2, trazumab. I'm not saying it right, but some of the MABs and the NIB medications here, CAR T medications and checkpoint inhibitors that are associated with cardiac toxicity. We have these. Oops, sorry, I went ahead. We're looking at these because they cause myocarditis, arrhythmias, and these ICIs are some more of the MABs and CAR T medications. I can't say any of these words, but they're here also. You have other medications here, the pyrimidines and targeted agents cause ischemia, hypertension, Q2 prolonging arrhythmias, and some of these medications are the 5-FU, and then targeted are and again, some of the MABs and the NIBs. Then we have the thoracic radiations, which could cause late coronary, valvular, pericardial, and conduction disease. Common settings, mediastinal RT for Hodgkin's lymphoma, left-sided breast cancer, lung cancer, esophageal cancer. So again, we want to emphasize that oncology nurses are the first to recognize the subtle changes, and we want to connect drug classes to typical cardiac effects and identify high-risk patients early. Then we're looking at clinical presentation and diagnosis. Again, these oncological cardiac toxicities may present acutely. We'll see arrhythmias or myocarditis. Treatments are needed. So they're echocardiogram, troponins, cardiac MRIs, BNP biomarkers, and then left ventricular EF. So we're looking at the ejection fraction for these patients. So we want to make sure that early cardiac diagnosis in oncology patients is a key to balancing effective treatment with heart health. More management and prevention here. Proactive management of oncological cardiac toxicity requires early detection, treatment modifications, and cardioprotective strategies. So again, early detection, looking at their dosing and if adjustments on their treatment can be modified, if there's any alternative therapies, if there's any lifestyle modifications. So 3 phases, we're looking at baseline of the patient. Once that treatment starts, if that treatment can be dose adjusted, and then follow up with their treatment team. So ongoing monitoring and early detection. Risk-based surveillance frequency depends on drug class and dose and baseline for that patient. We want to track their biomarkers, blood pressures, echocardiogram. We want to watch for early symptoms of dyspnea, edema, fatigue, chest pain, palpitation, dizziness. One of the red flags here is for myocarditis, new chest pain, dyspnea, palpitations, their elevation of their troponin levels, and new or worsening arrhythmias. So we're focusing on nursing assessment at every shift, and we want to escalate any early symptoms that are indicative of biomarkers, their ECGs, or their echo. How we escalate, we want to make sure, again, we are providing information to both hospitalists and oncologists. We are looking at cardiac protection medications, parameters, it should say, for continued use, and when to notify providers. Ischemia and myocarditis can be acute and life-threatening, especially with the 5FUs and ICIs. We want to look at pericardial and vascular effects, thrombotic and pericardial complications, and then the clinical impact, hospitalization, treatment, interruptions, and then reduced quality of life. So toxicity affects both patient safety and cancer treatment continuity. So we want to link complications to bedside observations and assessments. We want to reinforce that the effect of toxicity on both patient and safety. Again, both patient and safety cancer treatment are bridged together. This one here. So symptoms, triage, and provider escalation. So tier 1, routine monitoring. So stable vitals, no new symptoms. We document findings and continue schedule assessments per protocol. Tier 2, we want to, if this is escalating for the patient, so they are now having new onset of dyspnea, edema, weight gain greater than 2 kilograms. There's blood pressure changes, mild palpitations. This is where we want to bring in conversation with both the hospitalist and provider before we continue on with the next dose or regimen of chemo treatment. Tier 3 is urgent escalation. So they are having chest pain, syncope, elevated troponins, BNP rise, ECG changes, sustained arrhythmia. This is where, again, we're talking with both hospitalists and the oncologist to either hold the treatment or maybe dose modify. Here we'll also request a cardiac workup for that patient. Tier 4 is emergent, so suspected ICI immune checkpoint inhibitors. There's myocarditis, there's instability, severe dyspnea. There's ventricular arrhythmia. This is likely where we will call for a rapid response for the patient either to be transferred to a step down or ICU. I don't know why I put ED. ICU, a step down or ICU area. So we want to make sure that we are doing closed loop handoff and we're documenting symptoms, vitals, trends, times of notifications to the providers. We want to link complications to bedside observations and reinforce the effect of toxicity. Where am I? I think I went ahead here. And here, highlighting acute toxicity versus chronic toxicity and what that looks like. So occurs during or shortly after cancer treatment. We'll see arrhythmias, acute myocarditis, pericarditis. We'll see sudden drop in ventricular functions, left ventricular functions. We'll see acute coronary syndromes. This is where we can incorporate our ECG monitoring for rhythmic changes, our echoes, looking at our troponins and BNP biomarkers, and then the cardiac MRI. We're going to be emphasizing a look at that. Chronic toxicity develops months to years after completing the cancer therapy. So they might have a dilated cardiomyopathy. They might have issues with chronic heart failure, which is the HFrEF, restrictive pericarditis. So we're monitoring their baseline echo before continuing their treatment, repeating an echo during each treatment cycle, and then annual cardiac biomarker screenings for these patients. Complications of cardiac toxicity, again, heart failure and LV dysfunctions, may begin silently and progress over time. Arrhythmias and conduction issues, so Q2 prolongation, heart blocks, sudden cardiac events, again, ischemia, myocarditis, and these can be acute and life-threatening, so we have to escalate this promptly. We're looking at that pericardial issue again, so thrombus and pericardial complications during or after therapy. And then managing and prevention of cardiac toxicity here. We want to look at cardiac history review, biomarker assessment risk, before initiating cardiac therapy, establishing cardiac baselines, regular left ventricular ejection fraction monitoring, and sorry, screens and then follow-ups, so long-term echo follow-ups, cardiac rehabilitation, and lifestyle modification. Managing cardiac side effects, so team-based care, so coordinating nursing, oncology, cardiology, and pharmacy for integrated management. Manage risk factors, so optimizing blood pressure, diabetes, lipids, smoking cessation, and volume status proactively. We're looking at treating dysfunctions early, so implement heart failure directed therapy and cardioprotective strategies. And we want to modify cancer therapy, so either again holding, adjusting, or continuing cautiously with close cardiac monitoring as clinically indicated. And then again, focusing on the ICI's myocarditis, which is emergent. So if we want to make sure we're treating suspected immune checkpoint inhibitor myocarditis as an emergency. Key takeaways from this one is know your regimen, know probably the history of the patient's cardiac risk, verify baseline testing, assess the patient every visit. So watching for dyspnea, chest pain, edema, palpitations, fatigue, and vital sign changes. Looking for those red flags and when to escalate for urgent care. And then also escalating to our providers, both hospitalists and oncologists. And I was going to do a patient scenario for this one. So I don't know if you've had a chance on my previous slide, Erica, or the PowerPoint for this one, if you had a chance to review the scenario, and I'm open for suggestions.
I haven't yet, but I can
scenario.
definitely take a look at it and we can see. I had a question about, oh, you have a couple more slides. I can hold out to the end.
No, these are just the scenarios.
Oh, okay.
So go ahead.
I was gonna say, the question I have is about when should we ask for a cardiology consult for the patient? When is that like recommended for them? Like, do we need to wait until they're experiencing some symptoms before we have a cardiologist involved? Or do we have to have like, you know what I mean? Like, can it be ordered like preventatively? I just don't know that much about when or how we would order the cardiology appointment, because I feel like they're another specialty again, right? And so
Yeah.
I don't want to bring them in too soon on it, but I feel like this is something that if we are having cardiac toxicity for, we want to make sure we are bringing in the cardiologist, because even though we're doing these things to prevent it from happening, and once we see it, we can, hold the treatments and all that stuff. What does it look like on the other side of it? Will they have heart damage for, the future? Will that recover? Is that a cardiology kind of discussion?
I think possibly, and again, I'm not at the bedside. Um, I think bringing in the cardiologist, especially if the patient has history of some of these cardiac issues, especially if their left ventricular ejection fraction is already kind of on the weaker end, and I have to look at that, the scale for those. We probably want to bring them in sooner than later.
Yeah, because I feel like, and Beatrice and Gia, you can correct me when I am wrong, if I am wrong. I think the ejection fracture standard is like 45% or better for most chemotherapies. They don't want to do it if it's not at least 45%. Is that the normal standard now still?
In my experience, I mean, a lot of them are coming back 60 to 65. If they're the lowest, I think I've seen is like 50. But usually their EF is not too far off, like, from the normal 60 to 65. And cardiology usually isn't called in kind of until after the symptoms. So if, the Zofran is on board, they're stopping that. They're doing all of this stuff to prevent it before calling cardiology in. I think they try to reverse it as much as they can, stop whatever they need to stop, and then they get cardiology to come in. If they're at a high risk, I think cardiology comes in. And then if they need to just monitor peripherally, they'll do it that way. But we can't get them in too early because cardiology is just going to say they're busy.
Right. And
Yeah,
then
I think I've seen a lot if the EF is normal, there's really no cardiology involved.
so
But a lot
when
of
do you see
time,
on the protocols, Gia? You know how we always see on the protocols like the EF fraction, EF percentage has to be at a certain marker.
yeah, usually every cycle it will say, or let's say if it's an induction, it would say that the patient should have an echo at 3 months prior, within the last 90 days is what our policy, our protocol says. So if that comes back normal, they really don't do anything much. But a lot of times, like once the patient gets a cycle and there's some changes, then they'll repeat the echo and they're kind of concerned. That's usually, they're pretty good in referring them to cardiology, but
But once they become symptomatic, then they start bringing in the cardiologist.
right.
And then
But
they
it's
bring
not,
in the cardiologist early if, like you said, they've had problems in the past.
Okay.
Okay.
yeah, or if the result of their or echo is really not
Is
within
low,
normal.
yeah.
Okay.
And we're like, I don't know, should we do it? Should we not do it? Let's ask the cardiologist.
Yeah.
So if we want a determining person, okay.
Like for us, it's more the oncology is the one that is going to determine, because sometimes they're low. Like Dr. Tarani, one of the outside hospitalists, his patients are sick, and we're like, "Ooh, we don't really want to do that." And he's like, "Yeah, proceed, let's do it." And it's like, "Oh my gosh!" But Dr. Abdul Haq, Dr. Kari, even them, they're in the same office, same practice. Dr. Abdul Haq has a little different call than Dr. Bakari. Dr. Bakari sometimes are a little bit sicker. He has that hard conversation, but sometimes he'll do it.
Yeah.
Yeah, and also I think it just depends on, the patient condition. It's just something that really they think that might help, even though the echo is not really that good. They probably would proceed. I've seen it too.
Right. And I know that they do like some cardiac preserving medications. Like sometimes I see like Coreg will be like PRN, or like they give it to the patients to like help protect the cardiac muscle, not necessarily because they have like a heart rate issue or blood pressure management kind of concern. Do you guys see any other common medications that are used to help protect the cardiac function or the heart?
What did you say was the drug that you see a lot?
I see Coreg.
Oh,
I don't know that I've ever had any to protect. Like when I've asked, they want to stay away. Like, and usually the hospitalists want to stay away from starting any new cardiac drugs. I don't know if they're thinking of the rebound or they don't want them to get where they have to stay on them.
Yeah.
But there's not a lot of cardiac drugs that they want to start.
It's
Just as
only
a
if
preventative.
it's only if they become symptomatic, then they bring on the. Okay.
Yeah, I mean, for me, like I said, my experience, they're trying to do as much without any extra
Okay.
meds or any extra services. They want, the patient hopefully to be healthy enough that they can tolerate.
Right. Okay. And if we are going to continue any medications, I think it's a good point to stress with the nurses that there has to be parameters for those blood pressure pulse
Yeah.
medications, because I see that a lot where like they just put the order in and they don't give a parameter, and then the nurses are like, I don't know, because maybe the normal sitting heart rate for the patient is already low, and then now we have like this question that comes up. So I think if we reinforce with this education too to the nurses, like, hey, anytime you have a medication that affects blood pressure or heart rate, you want to make sure you have a parameter and that you're checking that blood pressure and heart rate within preferably the hour that you're giving the drug, because you don't want it to be, oh yeah, the PCA took that vial sign at 7 o'clock, but it's 10 o'clock now and I'm barely going in there, and it's, you know, a med kit that can lower the blood pressure. You know, we want to make sure the vital signs are relative to when you're giving the medication. So I
Okay.
think that would be good. That's a great presentation. Thank you. I'm trying to think if there's any other questions I can think of. Ladies, do you have any other questions?
No, not for me.
No, I think I'm good.
Okay. Well, we can, Sabia, we'll send out the presentation with the case scenario, and then they can read it and give some feedback on the case scenario.
Okay.
And then that's pretty much the rest of the training session. So if you guys have any general questions and answers, we can take those at this time for the classes. If you guys have any other, you know, needs or support, but I'm going to go ahead and stop recording so we can have additional conversations. So I'm going to stop my recording.